Good evening, everybody who has joined for this smart learning class of ISU and USI. And for today, we have Dr. Venkatesh Krishnamurthy who is the director of NU Hospitals at Bangalore. And all of you know him. He's a versed teacher and with clarity in his in the subject which he teaches. And I'm sure today he wants you to learn about the nuances of uroflowmetry and not only just look at 2, 3 figures and come to some conclusion, and be able to read it and interpret it in a better manner. So I thank you, sir, for your time and your efforts for this class. And I request you to please start. And Dr. Jaimin, Priya, Harsha, and Shruti were already told to answer questions which sir would be asking, but other students or other faculty members and teachers also can just interrupt and ask sir. So it will be more of an teaching class rather than a lecture.
Yeah.
Sir, you could please start, sir. Thank you.
Thank you so much, Sujata. Good evening, everybody. I hope this is useful. The whole thing is tailored to be a little more interactive than as a lecture. So, what we need to understand, the learning points in this will be to be able to analyze the different segments of the uroflowmetry graph and be able to arrive at a probable condition that the patient has. The definition is just for the sake of completion, a graphical representation of the urine flow pattern of an individual expressed in ml per second. I just want to know, Harsha, what
Yes,
do
sir.
you think is an indication for uroflowmetry?
To assess the patient's voiding, sir, to know if the patient has any urinary obstruction or any underactive tetrosis.
No, okay. So basically, the objective of why this was started was that we wanted to screen for bladder outlet obstruction. But over time, there are so many other conditions that can be confirmed with the performance of a uroflowmetry. So indications for this, as you said, we started off with probably looking for obstruction, but now we use it for completion of a diagnosis. For instance, somebody says, I have urge incontinence, and then you will see that the uroflowmetry probably bears out this. For follow-up post-therapy, again, when you've treated obstruction. The important things about before doing, typically it is that you simply send the patient saying, go get a uroflowmetry done. The person who performs has no information about the clinical condition of the patient in the vast majority of patients. First important thing is to counsel the patient. What is required? How do you go preparing? In fact, send them across to the uroflowmetry room where somebody can actually explain the process. The rest is very standard teaching, perform in privacy. Another important point, perform at normal desire to void. I stress this because quite often they come with a bladder overfull or it's less and then they're asked to drink a lot of water. And then suddenly there's this urgent desire, but then the uroflowmetry is not free. They're asked to hold because as a patient, so on and so forth. So the basic condition to perform uroflowmetry itself is flouted. And important, repeat if necessary. If it does not feature what the patient has come with, repeat if necessary. And the current standard is to measure residual urine. So counseling, we have a leaflet that is given to every patient. We ask them to read, visit the uroflowmetry department, and then come in prepared for the uroflow either the same day or another day. Have a small bladder scan machine. This is something that we have, but have a small bladder scan machine that will tell you whether the patient is ready for the uroflowmetry first, and also after voiding, what the residual urine is. Does somebody, Jamin, do you want to say what instructions will you give your patient for fluid intake? You say do a uroflowmetry. Do you tell them anything or you just ask them to do the uroflow?
So, sir, basically, the patient has to have normal intake of fluid, not excessive intake, and should be asked to just based on the frequency that the patient has. Based on that, when the patient has a normal desire, at that time only we ask him to get a Euroflow. I mean, it should not be like you have to take 2 liters or 3 liters of water in the morning and or when you come to the ward, and then we'll do the Euro.
Yeah. So you will see that quite often they stand over there outside the uroflowmetry room and then they are asked to drink a lot of water. They drink 1 liter, 2 liters, whatever. Forgetting the fact that depending upon the state of your prior hydration, what fluid you take now will reach the bladder only 2 hours later. So you have to be very careful about the instructions you give. The fluid intake for uroflowmetry typically has to be about 2 hours prior. And sorry. Two hours prior, about 2 glasses, about 400 ml, if they haven't had a lot of water already. This is all good for the adult age group. For the pediatric, you say 1 to 1.5 glasses of water or 5 to 7 ml per kg works for both pediatric and adult group. Before you send the patient across for uroflowmetry, and is there any information that you feel is important?
Yes, sir. So basically, I would like to know the pattern or the way he or she voids. And then there are some patients, there would be many patients from the rural area who would be just voiding in a squatting position and not in the standing position. I mean, they would be so the position with the patient voids and whether he will be able to normally replicate the normal voiding pattern. I mean, the voiding uh, situation.
Anybody else? Priya?
Sir,
Sir, I would like to ask for any history of any drug. He's either he's on medications like diuretics.
If the patient has any chronic
volumes, sir.
Sorry?
Void volumes, sir.
Yeah, basically, you will want to know there's a malfunction of my slideshow. Okay, let me get to that. Basically, you want a basic history. Suppose this patient comes to you with urgent incontinence, or they have frequency of urination, they're passing urine every hour and so on. Then it is important because you will have to pay a lot of attention to this patient to see that they don't have leak, they don't have urgency, they're not holding urine beyond their limits, so on. So a low urinary tract history, the ultrasound report, which shows, suppose there is gross residual urine, there's very little purpose served in getting a uroflowmetry done for this patient. In female patients, gross cystocele and prolapse, maybe that you want to do the uroflowmetry in a different way so that you don't overlook the presence of this, which can affect the uroflow. So the reality, why I'm bringing all this is the reality, as all of us know, especially in a busy urology outpatient, most of the time there is non-compliance with the instructions. It's either too little or too full. There's a lot of waiting time. There are patients in our own hospital, we had patients wait up to 8 hours to do the uroflowmetry. So these are things that you will need to keep in mind when you do a uroflowmetry. So what will you do? Make sure some basic information is given, which is important for the conduct of the uroflow. If you say that, look, this patient has urgency, cannot hold, or the ultrasound shows he's passing only 100 ml, then there is no point in asking this patient to hold on to urine and come with a larger volume. That may not happen. This is, I quote verbatim from Abraham's Urodynamics, excessive rapid fluid intake combined with delay. Don't know, just sorry, there is some.
We can see the slide properly, sir.
Okay, now I'm back to.
Okay.
Combined with delay in being able to pass urine will give a misleading result. It artificially reduces the Qmax and increases the post-void result, and is a surprisingly common issue in flow rate clinics because your results are going to be skewed. Patients even report urodynamic testing as easier and less uncomfortable than uroflowmetry because urodynamics does not involve having to wait with a full bladder. So remember this as the basic requirement for performing uroflow. Okay, so Shruti, what do you think is the ideal volume for void? When will you say, I will accept this graph because this volume is adequate?
Sir, for adults, the void volume should be between 150 ml to 400 ml, sir. 400 ml to 500 ml even might be accepted.
Okay, yeah. So this is what we want is the lowest acceptable volume, maximum uroflow rate. So you need, this is what we expect. So even though there is a variation in the volume, you will see that it affects the maximum flow rate. So basically it is this, you accept a minimum of 150 ml in the adult population, 200 above is good. Remember, there are some important things that you have to see, pay attention to. One is the paper speed should be set at 0.25 centimeters per second. Only a smooth urine flow is to be reported, which means you have a lot of these peaks that keep coming in several uroflowmetries. So you'll have to know what you are going to report it as. No graph is to be handed over without somebody signing off on that graph. The maximum flow is rounded to the nearest whole number. Voided volume or residual volume, either is rounded to the nearest 10 ml. And on a graph, when you see the chart paper, 1 mm on the x, 1 second on the x-axis, 1 ml on the y-axis, and 10 ml on the y-axis for volumes. Just remember this. These are standards. So you may find that in some machines, if the paper is going at a rapid rate, you'll find the graph stretched out. And if it is slower, then you find that it is compressed and you think that the flow is very good. Finally, if you are not satisfied, if the patient says, look, this is not how I pass urine at home, repeat the test. Don't hesitate. This is the normal graph. I won't spend too much time. You people are aware. This is described as a bell-shaped curve, but the ascent is a little sharper than the descent. The time to maximum flow is typically around 33% of the total flow time. The average, as any average should be, will be 50% of the maximum flow. This is the ideal graph to say that this is normal. The x-axis measures the, the y-axis measures the volume. This measures the time. You will get what is called a nomogram. There are several nomograms. For most part, it is of use only for in the research setting. You have the nomogram, but there are different nomograms and they are not all in agreement. If you use different nomograms for the same parameters that you see on the graph, you will find that there is a variation. These nomograms are only on the voided volume and do not take into consideration the residual volume. Ideally, if you read, they will say it is mentioned that you have to take the overall volume. Anyway, you will get it like this, or you will get it as another printed list over here that says it is less by how much. So here is for the maximum flow where it is, and this is for the average flow. Generally, you look at the pattern and look at these parameters. I will go to each of these. So this is a normal flow. You will see that there's a good peak flow. The average flow as expected is high at 50% of the total. And the voiding time and the flow time are equal, which means there are no interruptions. And the other thing is the time to peak flow. The total time is around 16. The time is 5, somewhere around 30% of the total time. So for all practical purposes, this is an excellent representation of a normal flow. It's the same over here. There's very little difference between the voiding time and the flow time. You don't have the classic bell-shaped curve that has been said, but it drops down over here more rapidly. That is the same over here. Again, you find there's very little difference in the voiding time and the flow time are normal. There's a good flow. Don't go by only these. So again, over here, I want to show you the voiding time and the flow time. There is not too much of a difference. That's a 4-second difference. But you find that because of this, it doesn't mean it's normal curve, because if you look at the other parameters, you will know that this is a very flow plateau type curve. The next, what do you do if you have these spikes? See, these spikes are not normal. The bladder is incapable of such rapid contractions. And most of the flow meters, there are different types of flow meters, will only average out what is happening over a 1 or 2 second interval. And so you will need to smoothen this out. And this is called every 2 seconds, you draw a line, join it every 2 seconds without having any acute changes in the line that you draw. This is what you do. So here, the Qmax here is actually 8, and it is not the 16.6 that has been reported. Similarly here, it is 17 and it is not the 21.3. So you cannot release a report like this. It's the same here. So when you draw a line, you find that it is much less, and these are not the peaks that you take as the peak flow. It's the same here. The peak flow has been reported as 22.6 here or 23, but the actual flow is somewhere around 12.5. Have I made this clear?
Yes, sir.
Yeah. So here too, the peak is not 51.3, but it is somewhere around 37.5. Same here. So what is this flow time versus voiding time? Anybody? Harsha?
Yes, sir. Yes, sir. Voiding time is the total time duration of the flow, whereas the flow time is the time over which the measurable flow occurs, sir.
Correct. Yeah.
And the voiding time includes the time between each of the episodes of the interpreted flow also. Whereas the flow time, it only shows the measurable flow pattern, sir.
So what it means is that there are gaps. Again, it seems to be missing around this.
We can see the slide showing flow time versus voiding times. You're not able to go ahead.
No, I am not able to see it here. 1 minute. I don't know why this is simply jumping. Correct. So you will have to be very clear about what is important in this when you convey the voiding time or flow time. If there is no difference, the voiding time is the total time which has all these gaps in between. Yes, it says that it is a prolonged flow, but sometimes you need to know what is actually the flow time that is required, because you will know whether there have been long gaps between. I will come to it. I'm going to give you some examples. So in this, there's no difference between the voiding time and the flow time, as I showed you in the earlier normal graph. Now, if you look at this, here is a person who actually has an interrupted flow. Each time it comes down to the baseline, there are long gaps here. So overall, even though you may not have a perfect clinical diagnosis, you know that the flow is very poor, and the voiding and flow time, there is huge difference, and the time to peak flow is prolonged. If this were much higher, if the maximum flow were much higher, let us say it is 15 truly, then you know that this kind of difference is coming on later on in the flow towards the end. So here you are, 22.6 is the maximum flow. So there is a fairly strong bladder action over here, but after that, there is a long gap. And you can actually make that out by the fact that he's had a good peak flow, but the voiding time is prolonged while the flow time is only this. So you know that a major portion of this has been passed in the initial period. There's something else that when you talk of this voiding time, flow time, there's something else that you must see. You can have a false low. That is something else that contributes to a low average flow. Again, this is the same thing. So this patient has had a good flow in the beginning, but later on, he's spending a lot of time trying to squeeze out the last few drops from whatever sensation that he has. And therefore, you will find that while this could have been 15, you find that this has brought down the average flow over a long time. And that again speaks in this difference between the voiding time and flow time. Similarly over here, this patient has had a fairly good flow at the 15 ml peak flow, but towards the end is spending a lot of time, and you'll find a lot of patients who are coming to you with these symptoms. So when you study the uroflow, this will be a recurring point that I try to make. There's a lot to analyze in the flow and not just know that, oh, this is the difference between flow time and voiding time, but can you make any difference out of this? Can you make some meaning out of this? You will have to study the other parameters also that are there in the report and in the graph. Does somebody want to look at this flow? Any comment? Jamin?
Yes, sir. So initially there is a large peak in the initial part only, followed by a gradual decline, sir. And towards the end, terminally, there's one more peak which can be because of the squeezing effect, sir. And
Sorry, say that
so,
again.
so towards the end, there is one more peak, sir. So that could be, yeah. So that could be because
correct.
of the, yeah. So that could be
Basically,
just because of the sensation, could be because of abdominal strain or the squeezing.
yeah, correct. That is the squeezing of the external sphincter at that time to get out the last. So here what you see is a rapid rise to peak. It's a rapid rise to peak. So you know, while uroflowmetry typically is not supposed to give you a diagnosis, you can have a fairly good idea of what kind of condition you are dealing with. So if you look at this, he's had a good peak flow, but his time to peak flow is 0.8 seconds. That is in less than 1 second. So this is typically the patient who will present to you with urgency, urgent continence, and so on. Asking such a patient to hold on to the urine because the flowmetry machine is not free is very unkind or sometimes cruel. So, so time to peak flow, the time which is measured from the onset of flow to the peak flow. Normally 1/3 of the voiding time, but in this case, you will see that it is much more. Typically here. Now, these are patients very high peak flow. It's going out of the graph and a very short time to peak. Typically, this patient comes with a stress leak incontinence. So suppose I show you a graph and say, what is this patient likely to have had? It's very easy or fairly simple to say that this is what I would expect in this patient. Similarly here, you see that this is a vertical rise. vertical rise, the time to peak flows happened in 0.5 seconds. Again, this patient presented with frequency and urgency. So I've spoken to you about the peak flow, the average flow, the flow time, voiding time, how it makes a difference in what you will, what conclusions you will make from these. And now I'm talking of one segment, that is time to peak flow. Again, it's the same, very rapid, nearly vertical rise to the peak and a very slow down slope. This patient also came with urgent continence. One more, urgent continence. Now, in this, you see that the peak is actually at the other end. It's moved right on the graph. Out of a total of 19 seconds, the peak time to peak is 14 seconds. So if you look at, if somebody gives you just the values, that is 18 peak flow, average 11 flow, you would think that this is normal. But one small parameter in this entire list, this time to peak flow, gives you an idea of what is happening, that actually this is a obstructed flow. Maybe obstructed, maybe an underactive detrusor, but the point is that if the volume, the flow is, the peak flow is quite good, unlikely that it is an underactive detrusor, and more like the fact that there is a obstruction. Again, it's the same. This child came with dysfunctional voiding, so it takes a long time for that sphincter to open. And then after that, there is a drop. So there are various conditions which contribute to a graph like this. So pay attention to this time to peak flow. This bladder took time, has been taking time to recover. So even after fulguration of the valves, you find that the time to peak flow has moved right. Volume dependence. Now, this is something else that we have constantly talking about. Don't do it in an overfilled bladder, of course, and again, in an underfilled bladder too. Does it make a difference? Classically, you are told that yes, if the volume is too high, the flow can be poor. If the volume is high and the graph shows a good flow, you really don't have too much to worry. Let us take this patient. This patient, first one was a void volume of nearly 600. Here it is around 260. Now, if you look at this, you won't see, of course, there is a difference in the way the graph is, but even in such conditions, the initial part of the flow, graph and the latter part, terminal part of the graph, continue to be the same, similar rather, not the same. So it will give you an idea of what is happening. Again, I qualify this statement, even if there's a lot of variation. If the bladder function is good, there are no pointers to a severe obstruction, you don't expect too much of a change. Here, this patient voided 108 here and 577 here. So you see a marked difference. But again, remember, the speed of this was much slower. And therefore, you have something that rises like a tower over there. But if you take time to study the time to maximum flow, you will find that this is 15 seconds out of a total of 22 seconds, which means this is a slow rise to peak. Don't get carried away by the shape of this curve. And it is the same here, that it is 1/3 over here, it was better there. When it is over full, then there is a delay to the peak. Similar again here, past 618, past 223 over here. The graph essentially hasn't changed too much. Again, 120 ml here, 280 over here. If you look at that, there isn't, as I told you, the initial part of graph and the terminal part more or less have similar patterns. So it doesn't change too much unless this is at extremes of bladder function, which I will show you later. So this is the reverse. Here is voided 734 and here it's 280. So you see that this, though you see these variations, here it's more pronounced. Similar. Again, now, as I said, you will see a lot of difference if the degree of obstruction or lower urinary tract dysfunction is more extreme. So at 723 ml, this is the kind of interrupted flow, more like a staccato voiding. But when the volume is 300, you find that the curve is much better. And this is what we tell patients when we talk to them about urotherapy. You tell them drink only as much water as you need, do timed voiding. Classically, in the outpatient, you will find that patients come to you saying, I am all right, but early morning void, it takes me a long time to pass urine. I have to struggle to pass urine. And that is invariably because they have not voided or emptied their bladder in the night. The bladder is overflow and it takes so much more time to empty. Here too, low voided volume with a low peak flow, and you find that this is a urethral stricture. Typically, how will you confirm that the voided volume is representative? I don't know how many of you actually have a scan. So Jamin and Rupa, do you people have a bladder scanner in the uroflowmetry room?
So we have a sonography machine. So with that, we confirm the post weight.
You do that, okay. Yeah, it's
Yes.
very important that you do this. Unless you do that, you will unnecessarily keep subjecting the patient to a lot of trial of voiding, and your results are going to be very different. So you use it both. Was the bladder adequately filled? And then you look at it for residual urine. Two, how else do you know? You will know by looking at the bladder diary. You know what your void volumes typically are. So you know that this is adequate. Then the Euroflow summary. Sir, this patient came, peak flow is so much, voided volume and voiding time. Is that enough? So over here, who wants to take this? Shruti, do you want to take this? What is your impression on this?
Sir, as per this readings, the max flow rate appears to be average for a female. And
So
flow.
on the face of it, it looks all right.
Yes,
On
sir,
the face
all
of
right.
it, it looks all right. Am I right? Yeah. But there is a small point that see
Time
here.
to peak flow. Yes, sir.
Time to peak flow is prolonged, and that is what this will show. So on the face of it, it looks like, oh, peak flow of 20, average flow 12, voiding time is 27 seconds, so it's all right. But you see that there is a struggle to empty. Again, it's the same. This shows 19 maximum flow, finished voiding in 35 seconds. Of course, this is a little prolonged for this, slightly, but again, if you miss this time to peak flow, so if somebody says maximum flow is this, voided 320, 35 seconds or 33 seconds flow time, seems okay, but not really. This is the pattern of voiding. So don't stick to just mentioning the volumes. If you, I mean the numbers, if you have to, then add what else has happened, so like this time to peak flow, for you to get a better idea of what is happening. Same here. So this patient is past nearly 880 cc, 2413, but it does not, this does not tell you, other than the fact that the time to max flow is around 8 seconds. So it shows that there is some urgency. This patient presented with hematuria due to BPH. Similar. So don't just casually mention only the peak flow. And next is diagnosis. Can you give a diagnosis from uroflowmetry? Rupa?
Sir, Priya.
Priya, sorry.
Yeah.
Priya.
So we cannot get the exact diagnosis from the uroflowmetry. Still, in the case of stricture disease, there's a typical low peak pattern. So from that, we can identify the stricture. But to rule out other causes of bladder outlet obstruction, uroflowmetry is not enough.
Okay. Yeah, good. I like that answer because that is what we are coming to. Now, this is a patient who has what you call, would you say, typically stricture kind of flow. But what this patient had was actually prostatic obstruction. Why do you have this kind of a plateau in a stricture? Priya?
Sir, a patient is voiding against a high resistance. So it's a like a narrow stricture segment. The patient is voiding through that narrow segment for a longer duration. Still, he is able to void completely, but it will take a longer time to complete.
There's a
voiding.
fixed obstruction,
So-
sir.
Yeah.
Typically, the Qmax and the average flow, sir, in this patient almost the same, sir, because
Same.
there's a continuous mechanical resistance against which he is voiding. So it has the problem is not with the bladder pressures, but it is mainly with the mechanical obstruction. So typically, the maximum and the average flow rate will be the same, almost the same.
So
68.
typically what happens is the bladder starts emptying. The urine comes out into the urethra to whichever level the stricture is, and it's a fixed obstruction. So because it cannot take the entire volume, typically what happens is it is like an overflow phenomenon. Just like in the dam, the crest gates open and it will allow so much of water to come out. No matter how much water is there in the dam, the crest gate will allow only that much to come. So it is a fixed flow that is more like an overflow, which is why typically in a stricture you have this pattern. But remember, in stricture or in something else like BPH, you have to consider dynamic obstruction, static obstruction, mechanical, and the function of the detrusor. And therefore, to say with certainty that this is the diagnosis is going to be a little risky. But yes, you can hazard guess that this is what is going to happen. So this is a overflow. There is a pooling of urine proximal to the stricture, and then the stricture will allow only that much to come out. It's a fixed outflow. Again, here, now you have what is a very high flow. This patient came with UTI. In this, it seems fairly all right, other than the fact that the time to peak flow seems a little skewed, but not really. This patient had a bladder outlet obstruction, meaning these are patients who had undergone a urodynamic study. And this patient had an outlet obstruction. Similarly, here you will see dysfunctional voiding. You see the classic earlier, not now, the earlier description was that you'll have a staccato pattern of voiding, but that is not so. This patient came with recurrent UTI, and you'll find that the MCU shows that there is a narrowing in the terminal second distal half of the urethra. But for all practical purposes, other than the slow rise to peak, you will not have a clue if you go by the peak flow and the average flow. What do you think this is?
So this is the interrupted flow with patient having abdominal, it's voiding with abdominal strainings.
Yeah, could be abdominal straining, could be this voiding, but yes, this is due to prostatic obstruction and he's using a lot of abdominal strain. What is this?
Sir, can be
Interrupted flow.
dysfunctional or voiding in, yes, sir,
Can be
causing it
dysfunctional voiding, yeah.
due to rapid relaxation of sphincter and peaks and troughs. Peaks.
Yeah, typical staccato voiding, so that is dysfunctional voiding. So you can hazard a guess on what it is likely to be, but if you see, there is not too much of a difference between the previous graph and this. Again, you have this kind of intermittent flow and staccato voiding. This is bladder neck obstruction. And you find that while this has happened, after some time, it is only a straight line with the poor flow. I'm just showing you a whole lot of different kinds of graphs in which you may think that, yes, I know. Neurogenic bladder, if you have to say that this is something that you know from the history itself, I know that this is a poor flow. Except that you see that the P det is so high, enormous straining, and the flow appears to be quite all right, doesn't indicate such a bad bladder. And this is something that you must know, that if the bladder builds up enough strength to overcome the resistance, your uroflow may not show that it is such a severe obstruction. Anyone? Jamin, do you want to know what this is?
Just, sir, again, it could be so due to either a stricture or dysfunctional voiding, sir.
Yeah, so this is, yeah, correct. What is right, meaning when you say that I consider these possibilities, you're very right, because the Euroflowmetry can only tell you that it is good, maybe good, but may still have a problem, or that it is a bad flow. So these, the next 3-4 slides are all of underactive detrusor. I mean, I'm talking of, these are all proven by urodynamic study. And you will see that this is the kind of flow that you will have. Probably these are the extreme. These are the extreme, but remember, you can, the ultimate result of this, as I told you, can be because of the bladder, can be because of an obstruction, mechanical or dysfunctional obstruction. Okay, who wants to? Priya, do you want to give
Yes.
an opinion on this graph?
So this graph shows multiple peaks, sir, interrupted flow.
So I
And,
told you that the bladder is incapable of contracting
there's
and
not efficient
relaxing.
contractions.
Ah,
There's not
no.
no efficient contractions of the bladder, sir.
Okay. Anybody else? Shruti?
Sir, cruising artifact should we consider?
Cruising artifact. Anyway, basically, this is an artifact. You cannot have a flow like that. So this is the same patient, remember? So later we repeated it, and this is the flow. Not that it's a good flow. That kind of straining pattern also shows that it is a poor flow, but you repeat the Euroflow and you find that this is vastly different, and you have information on this, but you couldn't make out anything on that. So again, repeat if necessary. Don't stick to doing one thing and leaving it at that. Again, so this patient had all these artifacts. We repeated it and find that the flow is vastly different. Some unusual graphs. So this, any guesses on what this is? This was the first, and then this was the second.
The first one is pinching while voiding, sir.
Squeezing
Yeah.
of penetrating.
Correct. So typically, when they have a poor flow, then they squeeze the urethra and leave it so that they think they're getting a better flow, and that results in this typical pattern. So he had prostatic obstruction and he was doing this. This again is the same. They pinch and then leave and then again and pinch. Then you ask them not to do it, meaning you will have to ask them, why is your flow like this? Is this how it is? And they volunteer that they were pinching, and you'll be surprised. It's far more common than what you think it is. So pinching while voiding, and then we say, no, don't do that. Let us see. And then this is, again, this patient said, this is not my usual. He was not used to sitting and passing urine in a Western commode. So we asked him his normal voiding, and that was in the squatting position. So we asked him to do that, and his flow pattern changes. So the patient has to, when we say in relaxed atmosphere, privacy, in the manner that he or she is used to passing. Again, this patient was not used to passing urine standing. So we asked them to repeat, and the flow changes. Here is a patient you will see is using Crede's maneuver. Why? So you can make out this sort of thing, and then complete absence of any flow for some time typically is somebody who is taking his or her time, most of the time the men who neurogenic bladder, they do this. This is a patient for some reason got into this habit to pass urine using Kapalbhati. I don't know if you people are aware of what Kapalbhati is, but with our yogi, Ramdev, Baba Ramdev, he's been teaching this exercise, and this patient has been passing urine in this manner. This is the patient. Again, they say that this is not the way I pass urine, my flow is better. And then you ask what happened, and so they wanted to pass stools at the same time. Controlling to pass stools is not a good flow, and then this happens. No privacy, very conscious of what is going on around in the Euroflow room, and then with privacy, look at the difference in the flow. So to sum up, I want you to know, make sure the void volume is adequate, and that will happen only when you counsel the patient beforehand. Describe the flow, whether it's continuous, intermittent, poor. Has there been straining? Did the patient void normally? Meaning, is that how the patient passes urine at home also? Did the patient void completely? Whether the patient had urge. Now you can tell them that, look, your bladder is full, you pass urine. So did the patient have sensation to void? Don't go just by the appearance of the curve. It depends on the paper speed, as I told you, but look at all the parameters. There are so many parameters that are there that one graph and the notations of the various values gives you so much of information on what is happening with the uroflow. So the patient should have a normal desired void, should have a good volume, privacy for the patient void. Never look only for the Euroflow summary. As I've pointed out, there are so many variations in the curve. Both the curve and the summary are important for you to arrive at some kind of conclusion about the patient's probable problem. Thank you.
Thank you, sir. I think Chawla sir would like to just conclude.
Yeah.
Sir, are you there?
Yes, ma'am. Yes, ma'am. I'm there, ma'am.
Yes, sir.
1 minute, ma'am. Am I audible, ma'am?
Yes, yes.
Hello, sir. Am I audible?
Yeah.
Okay. I think, sir, one of the very, very good lecture on what you can say basic of Euroflowmetry. I think if you remember, if a graph is given in the exam to a student, how quick they are in just to see that this is a Qmax and this is and all that. But what you have shown is in the class is not just the numbers, it is the graph pattern. The all number have their own importance. And I think that has made this just one test of the basic test of urology made a very comprehensive. I think all the doubts from the resident would have got cleared had they been a little proactive. Every single point has been discussed very clearly, right from the patient preparation to conducting the test to interpreting the numbers, which is in the bottom, and the interpreting the graph, which is at the top, and the interpretation of the diagnosis based on the pattern and the numbers. Some tentative diagnosis can be given. And this is important, as you have told, that every Euroflowmetry has to be given a conclusion which should have a Qmax with the volume, with the PVR, with the signature and impression, what they get. And this has to be put by the resident or whatsoever. And what is important, what you showed in the slide, how the history is important, how the other parameter, whether you're seeing the bladder diary or whether you're seeing the residual urine and how you're doing. It made a very, very, what you can say, quality time spending and listening to your presentation. So thank you very much, sir.
Thank you. Thank you, Dr. Arun. There is one question. The reason behind the shape of the curve in Euroflow for BEP cases.
In the
chat group, somebody's asked the reason for the shape of the curve.
Okay. What is your opinion, sir?
So I didn't understand this question.
Yeah,
See,
sir. Actually, no, why the students are asking is sir. The most of the examiners are fond of asking this question. Why this pattern is coming? I think the some tentative explanation is given in Abraham also. They have tried to make this pattern as compressive, which is a BPH, and constrictive, which is stricture. The compressive being is of a prostate pathology, where it's not a fixed pathology, and some amount of changes are seen during the dynamic flow pattern. In the fixed narrowing area, fixed narrowing, you get the Pleshu or Messner type of graph, which is a representative of stricture. But again, these are tentative. Means these are mentioned in the book. As you have shown in one of your presentation, the patient has a BEP, but if you see the flow pattern was looking like a stricture. And we also see in many times the student will say, "Shall I do an ASU?" for this, it is looking like a stricture. No, just repeat the graph again. And the graph is different. The pattern is looking different. So it is not that. It is your clinical judgment is very important, what you are thinking and how you want to interpret. But one, again, what sir was telling, if you have any remote chance that your what the history you have taken and what pattern you are getting is not correlating, repeat the graph again with a adequately filled bladder when the patient has sensation. Please repeat. And sometimes one single urofilmetry you try to depend upon a diagnosis, this may come wrong. Yeah.
Yeah.
So there are a few questions in the chat box, sir. I think Jaimin has some question he has asked.
Yes, sir. So, what is the significance of doing a second PVR and when exactly is it indicated, sir?
So the fact is that when a patient has residual urine and if it is gross, there are two things. One is the practical aspect. Maybe the situation there was not good, which is why the patient has a lot of residual urine. The other is, given some interventions, will the bladder be able to empty better? The fact is, if at second void, the patient is able to empty, then the things are much better than if he is not able to empty the bladder. So that is when you put in urotherapy, timed voiding, ask them to relax and choose their way of passing urine, avoid constipation. When you do all these, quite often the person who can empty the bladder fully at second void is much better placed than somebody who cannot. These interventions will work for these patients. And of course, the fact is that you can try medical line of therapy.
Yeah, Jamie,
Yes,
which
sir.
is very. Yeah.
There's
Go ahead.
one, I think Dr. In the chat box, Dr. Chandra Mauli wants to ask some question. Please go ahead, please.
Madam, can you hear me?
Yes, yes,
Hello,
we
can you
can
hear
hear
me?
you.
Yes.
Yeah.
Hello. I'm a first year student, so my question may be very simple, but because in the summary we go for the first max flow, then average flow, then voiding time, flow time, time to fill flow. What is the reason for this arrangement? Is it that we have to first see what is the max flow? Because Sarah has told that some cases you have to see the voiding time and flow time, whether it's equal. Then we have to see. I just want to see in which order we have to see. Or is this the order that is very useful, that we have to see max flow first, then average flow, or voiding time, flow time? I think you understand my difficulty, please.
You will have
Sir,
to.
he wants to know the pattern in which he should read a flow and read a
No,
flow metric.
see, each of these has a sort of standard. There's a range. So in my earlier slide, I showed you for a volume, what would you expect the peak flow to be? But overall, you have to put everything into the picture before you will come to a conclusion. For instance, I've shown you where the peak flow is high, but then the after time to peak flow is very delayed, or the average flow is very low, or there is a prolonged voiding time. Then obviously that peak flow is of no use. Suppose the average flow is very poor, then you know that either there is a struggle to empty or effort to empty in the last bit, or you have an interrupted flow, so the voiding time is much more. So all these things matter. So you can't go only by one of which is more important. No. The point is you'll have to look at all the parameters given there for you to arrive at a conclusion. Yeah.
So if there are no more questions, I think, so definitely your presentation would be viewed and reviewed and people
Ah.
would be here to learn from it. And I'm sure it was really a very good teaching session, sir. Thank you very much for your
Thank you.
time, and
Thank
thank you
you.
for participating, Jaimin, Priya, Harsha, and Shruti. And thanks to everybody to taking part. Good night.
Good night.
Thank you.
Thank you, sir.
Good night.
Thank you.
Thank you,
Thank
sir.
you.
Thank
Thank
you,
you.
madam.
Thank you.